record. All right. Well, welcome everyone to Weekly Rounds. Our guest this morning, Dr. David Bewick, needs no introduction. Much like cardiac amyloid, if you haven't heard of David Bewick, then you probably haven't been treating heart disease in New Brunswick. And without further ado, David has done a nice job of pre-recording a talk, and he's here in person to answer any questions afterwards. So I'll start the presentation, and then afterwards, please chime in with any questions that you may have, either using the chat or unmute yourself and ask any questions. This is an interesting topic that has gained a lot of steam in recent years, and clearly, as you will see from the thrust of this presentation, it is likely something that I haven't really kind of allowed to enter my radar until recently. So I look forward to learning a fair amount.
Welcome. Today's talk is on an enigma wrapped in a riddle. And this is a bulletin for all the cardiologists and cardiac surgeons listening. Cardiac amyloid is no longer an untreatable zebra. If you have not seen a patient with cardiac amyloid, you've likely missed the diagnosis. I hope to highlight this with a couple of case examples that presented to the Brunswick Heart Centre. This is really a heart failure journey. Patients classically present with predominantly right-sided heart failure due to high filling pressures in the right side of the heart, as this is a restrictive heart disorder. However, the echo, although sensitive, is not specific. So one sees left ventricular hypertrophy, which is pathognomonic of amyloid infiltration, but one can also see this with a hypertrophic cardiomyopathy, hypertensive heart disease with renal failure, or lysosomal storage disease, such as Fabry's disease. I'd like to talk about two. The first one is a 69-year-old man who presented in the spring of 2018 with progressive edema going up to his thighs and was seen by cardiology in the fall with shortness of breath and generalized weakness. He was placed on furosemide and metoprolol, seen by his local cardiologist, and after an echo was diagnosed with a hypertrophic obstructive cardiomyopathy. The echo showed significant asymmetric left ventricular hypertrophy with a small left ventricular cavity size and hyperdynamic function, impressive left ventricular outflow tract gradient of 101 millimeters of mercury. There was chordal SAM, but trivial mitral regurgitation with a dilated left atrium. Severe diastolic dysfunction was noted. In addition, a chest X-ray showed a large left pleural effusion. In the apical three-chamber view, one sees basal septal hypertrophy, and on the long axis, one can clearly see SAM with the anterior mitral leaflet abutting onto the basal septum. In color Doppler, one can see eliciting in the left ventricular outflow tract. In addition, late systolic mitral regurgitation. CW demonstrated an impressive LVOT gradient of 5.03 meters per second, which translated to 101 millimeter gradient across the LVOT. One can see here severe obstructive hypertrophic cardiomyopathy, with highlighting by the arrow showing the basal septal hypertrophy and the SAM, which creates the obstruction and the subsequent high gradient. The management consisted of the patient being referred to the MP Heart Center, and a cardiac catheterization demonstrated normal coronary arteries and confirmed the high left ventricular outflow tract gradient of 100 millimeters mercury. He was seen by one of our cardiac surgeons and is accepted for a septal myectomy. But the astute cardiac surgeon didn't feel quite right about this patient's overall condition and asked if I could review him and give me a second opinion. So I saw him in February of 2019. Remember, he was diagnosed with a hypertrophic cardiomyopathy in the fall of 2018. And this is where the history is important. He had functional class 3 dyspnea, but had significant edema up to his thighs. Despite his edema and shortness of breath, he had no P&D or orthopnea. He was laying flat on the bed when I was talking to him without any respiratory distress. He had altered taste or dysgeusia and weight loss of 40 pounds. This is commented by the interventional cardiologist who took his history, said he had lost weight because he could not taste his food. The importance of the physical exam highlights several abnormalities consistent with cardiac amyloid. His blood pressure supine was 90 on 58, and then standing was 66 on 54, severe orthostatic hypotension. His JVP was distended to the angle of his jaw and increased with inspiration. He had macroglossia with indentations laterally from his teeth. He had dullness to percussion with reduced vocal fremitus on his left lung. His right lung was clear, consistent with a pleural effusion. His apex was sustained with a peristernal lift with no thrill. He had a harsh 3 over 6 mid-systolic murmur, which intensified with the strain phase of a Valsalva maneuver, classical for a dynamic left ventricular flow tract obstruction. And he had these peculiar abdominal pulsations with 4+ edema to his thighs. This gentleman has macroglossia, has a large tongue, and you can see where I have the arrow with indentation on the lateral aspect of his tongue from his incisor teeth. One can see this prominent pulsation of his venous pressure, and with inspiration, how the venous pressure increases the angle of his jaw. That's a Kussmaul sign, suggesting very high filling pressures in his right atrium and right ventricle. And I searched the internet and Google for this sign, so I could not find it, so I coined it the ripple sign, because he had these peculiar pulsations in his abdomen. If you watch his abdomen, you can see how it's pulsating. He did not have an aortic aneurysm. When one with his JVP and simultaneously the pulsations in his abdomen, one can see how the pulsation in his neck, the A and B waves, correspond to the double pulsation one sees in his abdomen. Also note the ecchymoses in his lower abdomen, characteristic for purpura from amyloid. The treatment consisted of combination diuretic therapy. His metoprolol was discontinued due to hypotension and a low pulse, and he's admitted to hospital for further investigations. His ECG showed reasonable voltage, but Q waves in V1 and V2 with lateral T wave inversions and an intraventricular conduction abnormality. His chest X-ray showed a large left pleural effusion with a clear right lung and borderline cardiomegaly. He had several abnormalities on his lab investigations. His biomarkers were elevated. Interestingly, his LDL was high at 4.8. His total protein was low and his albumin was only 16. His urinalysis showed protein, and a 24-hour urine collection revealed 2.4 grams, consistent with nephrotic syndrome. And one of the differentials of dyslipidemia or high LDL is nephrosis. He went on to have an echo and an MRI. One can see here severe diastolic dysfunction. His E/A ratio is high at 2.4, so it's over 1.5. That's considered high. His E/E prime was high at 36, showing low tissue velocities. He had a characteristic bullseye pattern on the global longitudinal strain. We have apical sparing. And what was impressive was the rapidity of his left ventricular hypertrophy. In September 2018, you can see his LVH. Look in March, 6 months later. Look how thick the ventricles become. This is an infiltrative toxic cardiomyopathy. His MRI showed late gadolinium enhancement, particularly in a gradient from the subendocardium to the epicardium. And one can see very impressive LVH on his Further investigations included a thoracentesis, which was a transudate and was negative for malignancy. A repeat 24-hour urine now demonstrated 5.6 grams, previously 2.6 grams, so significant abnormality of renal function. His genetic screen was negative for hypertrophic cardiomyopathy. Serum immunofixation did demonstrate a monoclonal protein, and he had high serum free electrons. Went on to have a cardiac biopsy, which was positive for AL amyloid. The bone marrow showed abnormal plasma cell line, and he underwent chemotherapy for multiple myeloma. So this patient was a hypertrophic cardiomyopathy masquerading as cardiac amyloid. Hypertrophic cardiomyopathy has a favorable prognosis, but if it's due to AL amyloid with heart failure, there's a very poor prognosis, generally 4 to 6 months. It's mandatory to make a correct diagnosis clearly in this setting. And the presence of a high LVOT gradient with amyloid is very rare, frequently underrecognized, underdiagnosed. When the second patient presented at the MP Heart Center and seen by many specialists, is an 82-year-old white farmer who is physically active and very independent, works in his barn daily in the country. At age 75, he sees a cardiologist because he's now short of breath in 2013. He had risk factors, including diabetes and hypertension. And this is what I call the journey. Most of these patients see many specialists. In fact, up to 25 to 30% of patients will see 5 or 6 specialists before a diagnosis is made. And he highlights this journey. In 2013, he had a normal ejection fraction with LVH, mild aortic stenosis. 2014, had a stress echo, could only walk under 3 minutes on a modified Bruce protocol, with the endpoint being fatigue and breathlessness. A CT angiogram showed heavily calcified coronaries with an occluded LAD, and the circumflex had a severe stenosis, which was confirmed on coronary angiography. He went on to have a PCI for his occluded LAD, but it made virtually no difference to his shortness of breath. 4 years later, he's still short of breath, and now it's progressing. He cannot work in the barn. He now has an echo, which suggests aortic stenosis with a mean aortic valve gradient of 28 millimeters mercury and a valve area of 0.9 square centimeters, significant LVH with an elevated pulmonary artery systolic pressure of 50 to 55. The patient said he cannot do anything. The family and patient are very frustrated with his progressive downhill course, despite being investigated and had numerous cardiac investigations over 5 years. One sees here his impressive LVH in the septum. He's got mitral undercalcification and has evidence of aortic stenosis. The peak velocity was 3.78 meters per second, with good left ventricular function with apical hypokinesis to akinesis. You can see the aortic valve is tricuspid and significantly calcified and appears to be restricted in systolic excursion. Visually appears at least moderately stenotic or more. The mean gradient was 33. One can see the inflow, how restrictive this is, with a high E velocity and rapid deceleration time. In 2019, remember this has been going on since 2013. In 2019, he was again seen by his cardiologist with congestive heart failure who recommended repeat cardiac catheterization. This demonstrated a patent stent with branch vessel disease, a 70% lesion in his circumflex and his OM. His LVDP was very high at 30, and the mean gradient across the valve was 30, what you've been keeping at most with moderate aortic stenosis. These are red flags. This was the clue here. He went on to have a PCI of his circumflex and OM with absolutely no benefit to the patient and continued to be functional class 3. He went on to be referred to the TAVI team, and pre-TAVI, the CTA was remarked by the interventional radiologist, severe spinal stenosis and prominent LVH. Those are in quotations. Again, another red flag. His cardiologist advocated for a TAVI as nothing else has worked. Give the benefit of the doubt. And I was at this meeting when this patient was presented. So he went on.
So you can just read the clinical course here. So he was back to the ER 3 weeks later after his TAVI with still heart failure and functional class 3 or 4 symptoms, elevated JVP, chest x-ray showed heart failure. Echo shows significant LVH with a normal EF. And I assume his aortic valve was functioning well. But once again, the red flag is what you can see on the right-hand side, physical examination.
Prosthesis was functioning properly. So here's a man who has had multiple assessments by various cardiologists, interventional cardiologists, and cardiac surgery. No improvement with PCIs or TAVI. The key learning points here, aortic stenosis by echo and cath was not severe for his incapacitating dyspnea and heart failure. His symptoms were way out of proportion to his valve disease. His biomarker was impressively elevated, the NT-BNP, and this patient was referred to rule out Bewick. He had classical bullseye appearance or apical sparing, by global longitudinal strain. Investigations including screening for myeloma, which were negative. However, a technetium pyrophosphate scan was strongly positive, grade 3, it goes grade 1 to 3, consistent with transthyretin amyloid. He was treated with combination diuretics, but remained hospitalized since the fall and died last winter while awaiting nursing home placement. The teaching points are this. In this patient, showed a progressive downhill course over several years with multiple evaluations by several specialists. There are several clues to cardiac amyloid. This is a multi-organ abnormality. He had severe spinal stenosis, disabling symptoms despite modest coronary disease and aortic stenosis. His cardiac biomarkers were significantly elevated, and that's due to the infiltration of the protein in the myocardium. His chest x-rays show congestive heart failure despite quotes in normal EF, and no improvement with PCI or TAVI. So what does one do with low flow, low gradient aortic stenosis and wild type transthyretin amyloid? This was taken from Jack in January 2018, looking at the prevalence of cardiac amyloid in patients referred for TAVR. A PYP scan is 95% sensitive for picking up TTR. They found in 101 patients who had a TAVR, almost 14% had a positive scan. Another group reported in the European Heart Journal, 16% of patients undergoing TAVR had occult TTR amyloid with a positive scan. And the typical phenotype for this aortic stenosis was low flow, low gradient, significant LVH, and a mild reduced EF of 48%. In circ imaging, 146 patients who had severe AS and a mean age of 75 had surgical aortic valve replacement, and all had CMR and intraoperative biopsy. They found 5.6% of these patients had amyloid, and they were all wild type under mass spectrometry. Look at the follow-up. If you're TTR positive, 50% had died at a median time of 2.7 years. This disease has to be identified before they are gone to seen by cardiology or sent to surgery. The take-home message is our occult wild-type TTR, previously known as senile amyloid, has a prevalence of 6% with poor outcome with a surgical aortic valve replacement. In another study, 1/3 of TAVR patients had amyloid. There's a high incidence of positive MRI and a PYP scan. And wild-type TTR is emerging as an underdiagnosed and unrecognized disorder, but an important disease modifier in patients with low-flow, low-gradient aortic stenosis. Patients who are older, who are diagnosed as hypertrophic cardiomyopathy, or in up to 15% of patients with heart failure with a preserved ejection fraction. The diagnosis requires a constellation of clinical, lab, and imaging findings. Typically, the echo shows a normal EF, impressive LVH, and significant diastolic dysfunction with GLS showing apical sparing. One should screen for AL or light chain myeloma. And we've talked about MRI, technetium pyrophosphate scans, genetic panels, and biopsy are selectively required. The history and physical are very helpful. This TTR is an abnormality of a genetic mutation in the liver, which produces, instead of a tetramer, it becomes unfolded, and you have amyloid fibrils being deposited in various organs, particularly the heart and neurological system. very similar to what a plasma cell dyscrasia does. Having the pathobiology of transthyretin amyloid is it should come out as a tetramer, but it gets broken down, what we call misfolded monomers, and then they get deposited either in the heart or neurological system, resulting in disease. So contemporary imaging in amyloid consists of the echo. We've talked about a very specific GLS, or global longitudinal strain with apical sparing. MRI can be very helpful as you have a gradient of amyloid deposition from the endocardium to the epicardium. And the PYP scan is 95% sensitive for picking this disorder up. So one approach to cardiac amyloid is clinical suspicion. The ECG and echo can be helpful. We've talked about the two types of cardiac amyloid, the AL or light chain amyloid due to plasma cell dyscrasia, and a genetic mutation, either spontaneous or inherited from the liver, resulting in amyloid deposition. So the approach to aortic stenosis and cardiac amyloid is not an infrequent disorder as one gets older. It can occur in up to 10 to 14% of patients referred for a TAVI. So the surgeons and cardiologists, along with interventional cardiologists, have to be thinking of this disorder. And the combination of aortic stenosis and transthyretin amyloid is complicated, both in diagnosis and management. The outcome of moderate or severe AS with cardiac amyloid, these were TTRs, 56% mortality in one, and another study had 37% mortality. These are not low numbers. A diagnosis of aortic stenosis and cardiac amyloid is in this algorithm, and this is all in the handout. So I've taken all these slides in the PDFs. You can go through these. Here. And lastly, how does one manage patients who have aortic stenosis and cardiac amyloid? And there's two types of amyloid, light chain amyloid versus TTR. Our patient would fit in the moderate AS category on the left-hand side, and one may have fallen this path, a clinical echo follow-up plus or minus a TTR stabilizer. So the key points in cardiac amyloid, the history and physical exam, high importance. Got to get back to the basics. It's a complex and vexing condition that requires a high degree of suspicion to diagnose and establish the extent of disease. And the clinical picture can be a complex interplay of multi-organ system involvement. The diagnosis is established with a combination of physical, biochemical testing, imaging, and tissue biopsy, with genetic analysis to establish what type of amyloid it is, for example, in transthyretin. Of course, the treatment is directed towards the AL or myeloma type versus TTR, but the future is promising for new treatment options are coming on board. We call gene silencers. So it's imperative to make an early diagnosis. Thank you very much for your attention.
That was great, David. Thank you so much. Excellent talk. And I think, you know, it's incredible that so many patients that we see really have so many of these symptoms and or signs. It's incredible that we haven't, I guess, misdiagnosed more patients along the way, or maybe we have, because, you know, how many people have we done AVRs or TAVIs on and they just haven't improved necessarily, and this might be part of it in a nutshell. I'll just let you comment, and then I will open it up to a couple of questions before 8:30.
Yeah, so it's thanks, Ansar, for giving me the opportunity to actually discuss this fascinating disorder, which I just keep learning. I've learned more in the last couple of years in this disorder than I knew in the last 20 years. And part of the reason is we are underdiagnosing it. And I meant that statement. If you haven't seen it before, you probably have missed the diagnosis. So I'm sure I've missed many people with this. The ones that I think we should be aware of are patients who have significant symptoms, as I showed in that those two cases, and the cath and the echo just aren't in keeping with the magnitude of the limitation. And the second clue is marked LVH with normal systolic function and high elevation of biomarkers. This is a toxic infiltrative cardiomyopathy. So the amyloid fibrils, when they get in the myocardium, irritate the myocardium and cause a rise in NT, BNP, and troponins. When you see troponins of 100, 300, BNPs of 5,000, and you're looking at the patient, they don't look that bad, start thinking of a form of a myopathic process rather than patients which we typically see with, say, for example, severe LV systolic dysfunction. And aortic stenosis, the low flow, low gradient, I think we have to start reassessing some of these patients. PYP scan is easy to order now. We used to call it a hotspot or infarct study. It's relatively easy to order, and it's basically it's like a bone scan, and it has a 95% sensitivity. So if you have this disorder, it will be positive. If it's negative, it virtually rules out TTR. So I think those are some of the take-home messages for the cardiologists and cardiac surgeons.
Absolutely.
I'll open up for questions.
So PYP scanning, how you say it's fairly easy to order. It mimics a lot of the tests that we've already done in the past, and that is this sort of a province-wide test that you would feel comfortable ordering in any center? And from an interpretation perspective, is it fairly, I guess, for lack of a better term, idiot-proof? Like, is this something that it's not left to the radiologist?
So thanks for those important comments. So there's no question that this was a journey just to go through the federal government to get this radio tracer, because it's nuclear in italics, and they weren't going to order it. I had to go to Alberta because they've been doing this for years. They have an amyloid center there. So eventually we got the government to agree that they would bring this tracer in. So that was the first journey. And I've talked to Moncton and Fredericton, and they now have the ability, because once we got all the hurdles, the regulatory hurdles over with, and we had established here, it was very easy to get in Moncton and Fredericton. So Moncton, Fredericton, St. John can all offer a PYP scan. In terms of positivity and negativity, I did mention the high sensitivity. Yes, we had a false positive. So your nuclear radiologist has to be up to date on not only looking at the scan, but also SPECT imaging. So you have to have SPECT imaging with this rather than just eyeball the scan. So there is, that led to a biopsy. I actually recommend a patient have an endocardial biopsy because they called it positive, which was negative for a biopsy. And we went back and went over with our contemporary nuclear physio, who has an interest in this, and he would have called it negative. So it's not idiot proof, so it does require some talk with your nuclear physicians.
JF, I'll give you
Thank you, David. This was great. My question relates a lot around the fact that, some of the therapies now we offer, the thresholds have become lower, and then you're tempted to offer therapy. Then in this setting, we should be, from what I gather from your talk, is the mortality is so terrible for these patients. We're not going to help them with our therapy, like TAVI, for example. That this is an important break to put on, and your thoughts around that.
So this is why you saw the last patient, and as I call it, the journey. He clearly did not benefit from many interventions. And in retrospect, now that we're aware of this, but again, you've got to remember, this is a relatively, quotes, new disease. It's an old disease, but was under-recognized. So we're just learning more about it now. It's like sarcoid. We thought we never saw sarcoid. Well, now that everyone's tuned into it, we see a lot more of it. I think if we had done a PYP scan when he presented when we discussed him at our rounds, and it was strongly positive, this would have given us pause to reflect before. I'm not saying you wouldn't do a TAVI, but we'd certainly have a bit more discussion, because mortality, once you get into advanced heart failure, so the patients generally have about 3 years. So, but the thing is, this can go on for 6, 7, 8 years. And as I call it, a journey. So they start off with LVH, because it infiltrates the conductive system disease. Not infrequently, they have atrial fibrillation with a slow rate without any rate control medication, because it infects the AV node. Then a surgeon may see him for a pacemaker because they have pauses, blackout. Then they get into heart failure. And then the journey unfolds, and then eventually one may or may not think about it. And with our TAVIs, I think it's worthwhile having these types of discussions because the next time we have this issue with someone who's got significant limitations, and everyone commented when we discussed that he couldn't walk. He was admitted to CCU. He could not walk around the loop. He was so short of breath after his TAVI, and say, well, it must be respiratory. So then you get respiratory. So these, again, I think he's maybe a bit more black and white type of patient, but we will see them more if we think about it. And I think it's a good opportunity we're the TAVI Center. We should start at least thinking about this, ordering biomarkers. If you're not sure, order a PYP scan. Fairly simple to order these screening tests.
Perfect. David, thank you so much. That, as JF said, that was a masterclass, and that was fantastic. I think we all learned a lot. And I will record this, obviously, and post it. And please look at the attachments that I sent. Both those articles are great summaries of this. One's Canadian, one's US, and I think it was well worth reading as we embark on our journey of trying to understand this disease process better. David, once again, thank you so much.
Yeah, no, thanks for asking me.